It's my pleasure to introduce you to Ms. Jody Steinhardt. Ms. Steinhardt received her Master of Public Health from Hunter College, and I've known her for a very long time, since when she was the director of a very successful community-based lung cancer screening program at Maimonides here in Brooklyn. In this capacity, she had extensive responsibility, including recruitment of eligible patients and developing outreach and marketing materials. As a matter of fact, I met her at a lung cancer screening seminar she coordinated at the Diker Golf Club many years ago. Since 2022, she's has served as Assistant Director for Lung Cancer Screening Program for the overall New York City Health and Hospitals Corporation, where she's instrumental in setting up programs throughout the entire system, like Bellevue and Kings County across the street. In this position, she created the nurse practitioner, navigated job description, assists with development of workflows, and assists with the identification and vetting vendors for the tracking software needed to make sure patients don't sort of fall through the cracks. So I can't think of a better person to give us a lecture. Lessons learned, the importance of navigation and care coordination. Thank you.
Thank you. Talking after so many great presentations today, and in the midst of an eclipse, we got to do this better next time in terms of timing and an eclipse and other wonderful things happening. So lessons learned. I have no disclosures. So I'm not going to go through the overview of lung cancer screening because we've already heard it 6 times today. But what I want to bring out is that in hearing it today from several different people, clearly there are a lot of moving parts when it comes to lung cancer screening. Lung cancer screening is unlike any other cancer screening. If you think about mammo, right? It's a gender and an age. If you think about prostate, it's a gender and an age. Colon cancer screening, it's all genders and an age. Lung cancer screening, it's an age range. It's whether or not the person has a tobacco history. It's the current state of the tobacco history. Are they still using tobacco, or did they stop using it? And depending on whose criteria you're looking at, depends on whether or not you ask them, when did you stop smoking? And it's a pack year history, which nobody knows how to calculate effectively. Nobody. And this is not just a Brooklyn issue. This is a worldwide issue, all right? Because when you're talking about a pack year history, I call it the art of the interview, right? If you ask somebody, are you still smoking? Yes. How much are you smoking? I'm smoking 3 cigarettes a day. How many years have you been smoking? Well, I've been smoking for 30 years. Well, 3 cigarettes a day times 30 years does not equal a 20-pack year history minimum, right? And if you leave it at that, at face value like that, you're totally missing that for 20 of the last 30 years, they were smoking 3 packs a day. It's the art of the interview, right? And then there's the math if you're not using one of the online tools for the pack year history. It's crazy, right? And then on top of all of that, it's no signs or symptoms. When somebody makes an appointment for a mammogram, nobody asks, right? And for the ladies in this room, back me up, right? Nobody asks, have you done a self-exam? Did you feel a lump? They just give you your appointment, right? Thank you, all right? I'm getting a couple of head shakes. Right? When a man goes for a prostate screening, nobody says to him, are you getting up 6 times in the middle of the night and dribbling, trying to pee? Those aren't questions that are asked. Lung cancer screening? Are you coughing? Did your cough change? Are you coughing up blood? Do you have fatigue? What kind of fatigue? And it's a whole thing because no signs or symptoms of underlying lung cancer. And then on top of that, it's, have you had a chest CT in the last 12 months? So lung screening is unlike any other cancer screening. Lots and lots of moving parts. So we're just going to go through these because we've already done these. The navigator. The navigator is the glue that keeps all of those moving parts stuck together. So that way, things can happen as seamlessly as they can. I'm not going to say that the navigator is going to guarantee seamless, because there's no guarantees in life, except, as my grandmother always said, death and taxes. But the navigator really does pull everything together and really reduces the chances that someone will fall through the cracks. So the navigator keeps the patient and the physicians informed, because it's not just for the patient, it's also on the provider side that we need navigation, right? Aware and engaged, thereby reducing the possibility of patients or findings being lost to follow-up. A lot of what I do, and a lot of my perspective where I come from as a health educator, is either based on personal experience or things that I've seen happen with family and friends. And I'm going to give you a perfect example of falling through the cracks, all right, which has nothing to do with lung screening, but it has to do with the way that I approach lung screening. My dad passed away January 1st of 2003. In 2014, my mom was diagnosed with early stage breast cancer. She hadn't had a mammogram in 11 years. Nobody caught it. Until finally, her PCP, her new PCP, looked and said, "You need to go for a mammogram." My mom was in her early 70s when that happened. Nobody caught that she hadn't gone for a mammogram in 11 years until that new PCP. Right? That's where a navigator comes into lung cancer screening. It is so important to have a dedicated navigator, not a navigator from your cancer center. You have to have a dedicated navigator just for lung cancer. Whether you want that person to only do the screening piece, or you want that person to take your patients from screening to treatment. Because like I said, there are so many moving parts. And it's all about the relationship. And I cannot stress enough about the relationship. So you have your ordering provider, and then you have your patient, and then you have radiology. At its core, lung screening is a radiology initiative. Without the scan, we have nothing, right? So you can have, depending on how your facility is set up, you can have lung screening programs that are living in radiology. You can have them living in pulmonology. You can have them living in thoracic surgery. One of our facilities, their navigator, their screening program is living in primary care, right? But radiology has to be the foundation. Because as I said, without the scan, we have nothing. Then we have pulmonary and thoracic surgery, because they're part of the team, obviously, right? Did we hear from a pulmonologist today? I don't think so. Yes. We did? Okay. Oh, I'm sorry. Okay, and then there's oncology, right? Because if you have, at some point, oncology needs to be in this mix, right? And palliative care. I actually love the model of palliative care coming in at diagnosis. A lot of people misunderstand palliative, and they think that palliative is hospice, end-of-life care. It's not. Palliative care at diagnosis helps people deal with the fact that they have a diagnosis. And it actually improves adherence to treatment. And not just for the patient, but also for the family and supportive people in their lives. Okay, so this is all the people that are involved in lung cancer, from screening to treatment, right? In the middle, you've got the navigator. The navigator is making sure that everybody is talking to everybody else and that everybody knows what's going on. So I happen to be a fan of the navigation-centric model in lung cancer screening. What it is everything goes through the navigator, right? Navigators provide the one-on-one hand-holding that makes people feel cared for. Now, all of us lived through COVID, right? For those of you who were actively involved in lung cancer screening during COVID, I have to think that just like the program I was involved with at the time, your screening program got shut down, right? My program got shut down for 3 months. And, thinking that, who knew it was going to be a 3-year thing? We thought it was going to be a short-lived thing, right? And so we shut it down in March of 2020, and we started scheduling people in June of 2020, the end of June. Well, this thing wasn't over in June of 2020, but we had to start bringing people back. There was already evidence that was published that with a 6-week delay in follow-up lung cancer screening, they were already seeing changes in stages of diagnosis. So it was like, no, we can't do this. We got to, we got to open up again. I can tell you, people didn't want to come. I was at Maimonides at the time. Maimonides has a cancer center that is about a mile away from the main campus. And I said to all of the people that we were calling, I was like, don't worry about it. We kept that facility fairly COVID-free because people were coming for their chemo and their radiation. And I will be there. Oh. And I'm not doing this to say, oh, Jody, I'm just giving an example about the hand-holding. Right? They were, oh, you're going to be there that day? Yeah, okay. And Maimonides finished 2020 at 97% of the 2019 volume. And that was with no new patients from March through December. Okay, it's all about the relationship. If you take nothing else away from this, from my talk today, walk away with it's all about the relationship. So who can be a navigator? Because there are a lot of different ways that people can be navigators, right? It could be a clinician, an NP, a PA. Our program at Health and Hospitals is NPs and PAs. As I said, nurse practitioner, physician assistant. It could be a health educator. I was the navigator at my previous program. I'm not a clinician. I have no clinical license. It could be a community health worker. I love the idea of using community health workers to be navigators. Actually, as we were talking about primary care earlier before lunch, I was thinking, darn, we should have navigation teams with a clinician, be it an MD, a DO, or an NP or a PA, and a CHW. Because in talking, all that we were talking about this morning with disparity and communities and populations, and we have to talk about culture, right? Because that's some of the disparity. We kind of sort of maybe touched on stigma, but we didn't really talk about stigma. Stigma is huge in lung cancer and lung cancer screening. A community health worker, how many people here are familiar with what community health workers are? Okay. Community health workers are people who are trained to be, it's a form of health education, right? But they're from the community and they work in their own community. So they understand how the community works, right? They understand the culture of the community. They speak the language. They are leaders in the community. They're seen as people who are respected. Their word holds weight. It would be wonderful to have a team with some type of clinician, health educator, and a community health worker. Or social worker. I'm sorry, social workers really shouldn't be at the bottom of the list, but I just clicked. There are clinical duties and non-clinical duties for the navigator. So the non-clinical duties, reviewing orders for accuracy. You mentioned the CPT and the ICD-10 codes. This is such a mess. I cannot begin to tell you what a mess this is. So many people use that Z12.2, the claim doesn't get paid, right? I review for all of our facilities. Sometimes what happens is they just take the diagnoses from the visit and they stick it onto the lung screening order. So I get lung screening orders with a primary diagnosis of diabetes mellitus. No, the claim's not getting paid. CMS is very clear. Those F17.02, that has to be the primary code. They're very clear. But there's only so much we could automate in an EMR, right? The navigator knows this. The navigator is not going to let an order that has a primary diagnosis code of diabetes get through. The navigator is not going to let an order that has a string of diagnosis codes, and one of them is cough. Not for a screening. Person's symptomatic. It's not a screening anymore. Right? These are the kinds of things that happen. You have a question? The insurance companies don't see it like that. The insurance companies see it as, but you're telling me this person has a cough, that's a symptom. I'm not going to pay you for the screening now. They shouldn't have been screened. Now, because there's nothing that the insurance company sees that this cough has been happening for 5 years. Somebody has COPD, they're going to cough. Right? It's that critical. You have to think from the insurance head, which I know. It makes people like a poltergeist. My head spins from the insurance companies. I used to say years ago that my gray hair came from my kids. Now I say my gray hair comes from dealing with the insurance companies. All right? It's crazy. You have to ensure that referred people meet eligibility. You said so many of the primary care physicians don't know the criteria. So you get people who, and again, the pack year history thing, it's not calculated correctly. So you get people who either don't have a 20 pack year history, or they quit smoking 25 years ago, if you're following the USPSTF of 15 years since quit, or you get somebody who's 47. Right? You have to make sure they meet the criteria. Somebody has to be, I hate to use the term, but for lack of a better phrase at the moment, you have to have somebody who's the watchdog. Track the patients. So many moving parts. It's the order. It's did they come in? It's did they get scheduled? Did they come in? Did they get their results? Did they come back? Right? It's the retention that's so important in lung cancer screening. Yes, getting them in the door for that initial screening is key. But if they come in and they never come back, we didn't do anything for anybody. They have to come back. And the literature shows that as programs mature, as lung screening programs mature, you find your cancers at earlier stages because you're looking for them, right? Health in hospitals is still really new. The program launched in October of 22 formally, so I can't really give you examples from health in hospitals, but I can give you 10 years of stuff from Maimonides, right? So at Maimonides, I can tell you we had a guy who came in 2014, lung RADS 1, 2015, lung RADS 2, 2016, lung RADS 1, lung RADS 1, 2016, lung RADS 2, 2017, this little booger grew. Stage 1. There were 2 women in April of 2022. One of them had been coming for 6 years, the other one had been coming for 4 years. Longevity is the key. You got to get them back in for retention. If nobody's tracking them, you've got a problem. And we're being recorded, right? Oh, darn. If you're not tracking your patients, you're asking a knock from the door from the courts. It's liability. Because if you lose them and then they show up with advanced stage disease, who's going to be blamed? You got to really keep that in mind. So it's the tracking of the lung rads, right? Why is that not going anywhere? Huh, I don't know what happened there. Okay, the lung rads, again, it's the when do they come back? What I don't think is in here, but I just want to point on, physician panic. And this usually happens with primary care doctors, right? Because we've already heard that their knowledge of the criteria is limited, right? The lung rads are very clear about when to bring people back. I don't know, I don't think it was explained this morning, but the lung rads are not based on the number of nodules. It's based on size and appearance. So you can have somebody who has 20 nodules and they can still be a lung rads 2, come back in a year. You could have somebody who has 1 nodule that says, oh, we got to get this person to diagnostics now. All right? So if physicians aren't aware or comfortable with the idea that their patients have nodules, they panic. And they go, oh my God, oh my God, oh my God. I had a physician once call me up. Their patient had a 2-millimeter ditzel. It's a lung rads 2, come back in a year. And he sent his person for a bone scan because he panicked, right? That doesn't help retention if the physician panics. The navigator can calm the physician, especially if the navigator has a clinical license. Navigator can calm the physician and say, wait a minute, there's plenty of evidence to show lung rads, this is what lung rads means, this is what lung rads does. It's okay. I'll make sure that your patient comes back. Don't worry. Because we all know that in the 15 minutes that the primary care doctor has to talk to the patients, they can only get so far. Okay, other findings. There's something called S findings, which I think I talked to later, but it has to do with significant other findings, because when you do a CT of the chest, you don't just see the lungs, you see the heart, you see part of the liver, you see part of the thyroid. I don't think you see kidney. It doesn't go down that far. But a little bit of the kidney. So, yeah. And retention. And also to communicate with radiology. Right? There's got to be communication with radiology. Like I said, radiology is the foundation of this. In terms of scheduling. And it could be either scheduling the initial or the annual. It could be scheduling the short-term follow-up. It could be scheduling the IR. Right? Communicate with the multidisciplinary care team. Every screening program should have what they call MDTs, multidisciplinary teams, right? Which are made up of all the people that I showed you before with the navigator in the middle. The navigator, because the navigator knows this person, because they spend time with them, they talk to them, they can add value to the conversation that doesn't show up in a test. They add value in terms of this guy, he's like so nervous, and we got to get him now because otherwise he's a flight risk. Or this lady has so many other complications, and we have to keep this in mind. Even, we were talking about social determinants of health earlier, right? You know, we really got to try and make sure that we schedule things on the same day, because this lady lives in a building and she's 10 flights up and the elevator hasn't worked in 6 months. And so we can't ask her to keep going up and down the stairs. We got to try and get everything done in one day. That's the added value the navigator brings. Obtain insurance authorization. Like I said, this is why my hair is gray these days. Insurance authorization is a pain in the neck. All right? The hoops that they make us jump through are ridiculous. Communicate with referring providers. So let me ask you, in terms of primary care, you send your patient for a test. How would you know whether or not how would you remember to look if they actually went for the test? And so you would need some kind of a tickler system to remind you to look in the EHR for the test result, right? That's not happening, right? Realistically, that's not happening. The navigator lets the provider know whether or not their patient showed up, whether or not their patient had to be rescheduled 4 times, whether or not the patient refused. If they're making the assumption the patient did come in, yay, making sure that the ordering physician gets the result. Yeah, they're going to get the radiology report, but the radiology report looks like everything else, and it's on the, I'm still thinking printouts. It's probably not printed out anymore. It's on the desk. You look through it fast, but a report from the screening program looks different. And it also reminds the ordering provider that the screening program has got it covered, and it's okay. And I'm not going to let go because I'm still the physician of record, but I don't have to hold on so tight. And I can do other things that are relevant to taking care of my patients. And provide reports for administration, which is huge, because administration has to know what you're doing. Because unfortunately, in this country, healthcare is a business. And so administration wants to know what you're doing and how well you're performing. And along with that is tracking the revenue, because unfortunately, in this country, healthcare is a business. The clinical duties are writing orders for the lung cancer screening low-dose CT scan. And I really do encourage this because, as I said, the navigator isn't going to make a mistake on the CPT or the ICD-10 code. Shared decision-making. I was at a conference from Rescue Lung, Rescue Life, which is up in Massachusetts, in late October. And there was a presentation there that said that they found that a shared decision-making counseling visit had to be conducted 2 to 3 times before the patient actually got it. 15 minutes a primary care doctor has to discuss everything that you came in for. Shared decision-making takes maybe 2 of those minutes. They're not getting it in 2 minutes, especially if there's cultural differences, there are language differences, there are other things, whether there are physical impairments of hearing loss or sight loss, right? People don't understand medical jargon, right? And we do. We tend to speak in medical jargon because it's our business. But the average person doesn't understand medical jargon, and translating it into everyday lay language is not easy, especially on the fly if you're not used to doing it. The navigator, that's what they do. Whether they're an NP or PA or a community health worker, that's what they do. They know how to speak to people. Smoking cessation counseling. We really didn't talk about this at all today. Now, I'm not saying that people have to stop smoking. I mean, it would be great if people stopped smoking, but we're not going to tell them you have to stop smoking, but we have to at least have the conversation. My take on it is that if you're doing a lung cancer screening program and you're not going to talk about smoking cessation with your screening participants, why are you having a screening program? I'm not saying you have to get them all to quit, but you have to have the conversation. And I've had people who have come up to me forthright and say to me, I'm not giving up my cigarettes. And my answer to them was, who said anything about giving up your cigarettes? Right? And then I knew, don't bother having the conversation because it wasn't going to go anywhere. But then there were other people who got it and they did stop smoking. So you have to have the conversation. The navigator could write the orders for medications as long as they're licensed to do so. They can review the scans. Many NPs, PAs, they know how to read the scans. They can review them. They can deliver the results to the patients with a phone call. Like I said when I first started this talk, a lot of what I do and a lot of my perspective comes from my personal experience or things that I've seen happen with family and friends. I'm a September birthday. The year I turned 40, I went for my mammogram. It was the Friday of Labor Day weekend. I was working for a nonprofit, so I got off early. I got home. There was an envelope in the mail from the neighborhood radiology place I went for my mammogram. And it was a checkoff sheet that said, we saw something, you need further evaluation. And all of my health education went out the door, and I became the patient who potentially had breast cancer with 2 small children. And I panicked. And I went nuts. And somehow or another, I got myself an appointment with a breast radiologist in Manhattan, right, for 8 a.m. on Tuesday morning. And my husband and I go into the city, 8 a.m. Tuesday morning, because Monday's Labor Day. And they say to me, I'm giving away my age here. They said to me, where are the films? And I went, Ubda. And they said to me, well, where's the report? And I went, Ubda. Because in my panic, I never thought it through, and I went there with nothing. And so I was able to get the report faxed, but that doesn't do much good, right? So there I was, next thing I knew, getting another mammogram and whatever. Thank God it turned out to be nothing. But I would never do that to anyone. When I first started in lung screening 11 years ago, I said, I will never, ever, ever send someone a letter in the mail if there's a finding that needs follow-up. It's too scary. You don't do that to people. You don't build trust like that. And provide peer-to-peer for insurance authorizations, which if any of you have ever done it, you know that it's a pain in the neck, and God bless. So more broadly, what the navigator can do is the outreach, both for patients and providers. Creation and dissemination of brochures, flyers, posters and signage, forums, health fairs, and symposia and grand rounds, which is how I met Steve Waite. So that's the navigation for the scan, for the screening piece. But there's other things that go on. So there's care coordination beyond the scan. The S findings, which I had spoken about a little bit. The ACR, the American College of Radiology, defines S findings as significant or potentially significant not related to lung cancer. So an S can be added to any lung RADS category. So you can have someone who's a lung RADS 4XS, right? So that means that there's something in the lung that is very highly suspicious for lung cancer, and there's something else we saw on the scan too. Be it a liver lesion, be it an aneurysm type thing going on, right? You could also have a lung RADS 1, which means there's no nodules in the lung, and you could have a lung RADS 1S. So examples of S findings are something in the esophagus, the thyroid, the breast. I have seen breast cancer caught on lung cancer screening. In the heart, in the liver, in the kidneys, in the large colon, in the spine. And so where does the care coordination come in? Tumor board, right? Hopefully you have tumor board or multidisciplinary review. A lot of people use those interchangeably. Referrals. The navigator can make the referral, whether it's a referral to pulmonary, or it could be the referral to endocrinology if something's found on the thyroid. As I said, the pulmonary consult, I talk faster than my slides. Follow-up imaging, biopsy, a thoracic surgery consult, and the duties could be scheduling, pre-authorization, tracking patient adherence, which is huge. Again, it's all about the retention. And there are lung screening organizations which do amazing work and really support screening programs. So how does that fit into the navigation and care coordination? Well, they keep program and personnel up to date. I only know what I know because I'm constantly at meetings, whether they're virtual or in person. I sit on several national committees, right? Get involved. It's the only way you're going to know what's happening before it happens. It allows for a free exchange of information. You learn things from other programs and how they work. And you say, oh, wait, that'll work for me, or something that works for you. Because, being in Brooklyn, being in New York City, we're very different. And, very, very different. Even from being in LA, we're very different. Support from the community of navigators. How many people here actually navigate a screening program? Okay. How many times have you felt like, oh my God, I have to be the only one? Okay, if you get involved in these organizations, you will be with 300 other people in a room at the same time going, oh my God, I have to be the only one. And then you're not the only one. Best practices. Again, it's about the workflows. How do you do it? What works for you? Oh, wait, let me see if I can get that to fly at my institution. Local, state, and national advocacy. I cannot stress this enough. I swear if I was 30 years younger and I knew what I've been saying, if I was 30 years younger and I knew then what I know now, I probably would have gone into policy work. The advocacy piece is so important. And I'm not just talking about the advocacy to get research funding, which we desperately need. I'm also talking about the advocacy in terms of screening itself. I mentioned something to someone today at some point about Brayward versus Becerra. How many of you are familiar with what's going on with Brayward versus Becerra? Okay. Do you want to say?
I'll let you take this one.
But I took the whole thing already. Brayward versus Becerra is a lawsuit that it came out of Texas. It's based on the fact that they didn't want HIV drugs being distributed to certain populations because of the HIV gay connection. And so what they're saying is that the USPSTF recommendations are unconstitutional because USPSTF is not a regulated agency, it's appointed. It's not, nobody's been elected to do USPSTF. And so all of the USPSTF recommendations from 2010 and later are basically in danger of being on the chopping block. Lung cancer screening falls in there, right? Mammo doesn't because Mammo was before 2010, right? This was on the news. This is still pending. Right now there's a stay. How long that stay will last is anybody's guess. This will probably end up in the Supreme Court. Okay? I don't know what your politics are. I don't care what your politics are. It doesn't matter to me whether you are a Trumpster or you're a Biden person or you don't like either of them, or I don't care. It's not my business. The only thing I can really strongly encourage all of you is no matter what your politics and who you're going to vote for in November, you have to pay attention. Because it affects what you do every single day in your work. I guarantee it. So examples of some of these organizations that I was talking about, the American Cancer Society Cancer Action Network, ACS-CAN, the New York State Cancer Coalition, under that is the Lung Cancer Action Team. Go-To for Lung Cancer, which is an amazing organization. Yes, I'm biased towards them. The National Lung Cancer Roundtable is also an amazing organization. The National Lung Cancer Roundtable has many different task groups and then subcommittees under the task groups. And that's how you know what's going on and what other people are doing and what works and what doesn't work. So the impact of the navigator: patient awareness and education, provider awareness, appropriate referrals, timely referral to diagnostic procedures and other services, and high program retention. And the navigator role in non-lung findings is informing the ordering provider of the S findings, because again, if the ordering provider doesn't know what the S finding is, they may not know what to do with it when they see it on the report. Facilitate referral to the appropriate service. And in conclusion, navigators increase referrals, they improve retention, they provide education and awareness to both patients and providers, act as a liaison between departments, and are the glue that holds programs together. And these are the references if anybody is interested. Thank you.
We had some very dynamic speakers, which I love. Thank you, Jody. So Dr. Phillips unfortunately had an emergency, so cannot make it. So we have a change to our regular scheduled programming. So Brooke O'Neill, who is one of the lead one of the core components of our lung cancer screening navigation program at Weill Cornell, is going to talk to you about an initiative that Weill Cornell is rolling out, which is our mobile screening unit. You guys all got a little handout, so we're just going to briefly talk about that, and then Dr. Sala will do closing remarks, and then for those of you who have just been waiting to see the eclipse all day, then you'll be able to get out on time. So thank you so much. And I think it's so ironic that a group of people who are not elected, who are actually appointed, are going to decide whether or not this organization that is also not elected but appointed is constitutional. So very interesting.
Hello, everyone. So Lauren, thank you for the introduction, and everybody please bear with me as this is completely impromptu. So I'm Brooke O'Neill. I'm a nurse by training and have been at Weill Cornell Medicine's lung cancer screening program for over 10 years. And I wanted to start by saying thank you to all of our speakers today, and a special thank you to Jody. You brought the navigation challenges and importance to life for us today, and I live and breathe this every day, and you just did a great job of just advocating for what needs to happen. So thank you very much. So prior to the lunch break, I awkwardly slipped some flyers onto your tables just to sort of share this project that is really near and dear to my heart and finally happening this summer to share our mobile CT program that we are launching in New York City. So you can see a picture here. We have a 40-foot vehicle. It kind of looks like a Winnebago, so it's not a tractor trailer. This is something that we actually can drive through New York City, much like the Mammo vans do, and park it with a SAPO permit on the city streets and bring this into the community. There are a lot of states that have rural areas that are reached by mobile CT units, but this will be the first in an urban environment. And there are actually tons of imaging centers in New York City, so why do we need a mobile unit here, you might say? And it's, from my perspective, and what we're trying to create is this is not just about the unit. This is about the lung cancer screening navigation program and building relationships with our communities. And Jody used the term, this is all about relationships. It's about with our relationships with our leaders, our elected officials. It is with community-based organizations. It's with clinics. It's with community members, with affordable housing areas. It is about building relationships that last. So the unit, is intended not just to show up once, say, hey, we scanned you, and never see you again, right? This is about coming into communities on a regular basis. We're thinking at least every 3 months per site, because that's the shortest term sort of lung RADS follow-up. There can be like a 1-month follow-up for some potential infectious findings, but at the very least coming back every 3 months so that patients can get their follow-up done on the unit. Our program also is ensuring that patients are offered tobacco treatment counseling. Jody, thank you again. I'm just going to keep preaching that. I'm actually a tobacco treatment counselor myself. Our NPs are all trained in this, and it is not about telling patients that they need to quit smoking, but it's about starting that motivational interviewing conversation. And we see many patients that have come back annually over time be more and more open to the conversation. I also think, and I could go down a rabbit hole on this, I promise I won't too terribly, but sometimes when patients get findings, And it doesn't just have to be a lung RADS incidental or a lung RADS nodule. Maybe it's the coronary artery calcifications, maybe it's emphysema. But the findings on a scan can be hugely teachable moments to help motivate people towards quitting smoking. So just something to keep in mind as you all speak with your patients about this. So, a lot of patients might not say they're ready to quit on year 1, but maybe year 2 or 3, they come back and they say, all right, Brooke, let's have a conversation. So we just keep at it, right? So the idea here, and if you look at the back of this pager, is that we're hoping to bring this unit to places in the community like federally qualified health centers, like health fairs, like affordable housing areas, things like that, just places where people congregate in the city. We're really focusing on Brooklyn and Queens to start out with. That doesn't mean that Staten Island is off the table. We all know that that's a hot spot that we need to frequent too. Really anywhere in the New York City area, we just happen to have really strong connections with our Brooklyn Methodist partners and our New York Presbyterian Queens partners, so we're really starting there. And we're hoping to link up with individuals that have relationships in the community to hopefully get some people to call us up, do the shared decision-making over the phone, over video visits with our nurse practitioners, such that they are booked, their pre-authorizations are done. All of those navigation hurdles have already been addressed by the time our unit is on site. Not to say we can't do walk-ins, but it's just a little bit more challenging with lung screening because of all the hoops. We can do about 30 scans a day on our mobile unit. That's about our max right now. It comes back to home base to charge overnight, but we don't need a plug-in or anything. And then the patients, whenever possible, will get a phone call the same day, depending on how quickly Dr. Groner is reading our scans and our other radiologist workloads. But that's important, right? We want to build that relationship with individuals as well, so they keep coming back and hand them off to providers in a very strategic way, following lung RADs, et cetera, in their local community. So we're partnering with our referring providers at our partner hospitals, but also hospitals that patients are already tapped into. We're not trying to take them out of their networks. So it's all about collaboration. I would say if there's a call to action from today, if you all are interested in hearing more, my information is on the back of this flyer, so please reach out. Any and all ideas, we have experience. We did a pilot at Metro Tech Center right on at the eve of COVID in 2019 into 2020. So we learned a lot, screening about 200 patients over a 2-month period during that, but we still have a lot to learn. That's why we're here, right, to learn from each other, to collaborate, and make an impact. The stat that I always use, and I popped on the front of this one pager, is that 6.2% uptake for eligible individuals in the state of New York is just abysmal, and every person here I know wants to make a difference on that, and this is one way that we hope will take off. So, if you have any questions, please reach out to me. If you know somebody or know somebody that might be interested in learning more, or collaborating, or is an elected official that, has constituents that they want to share this with, wonderful. Any questions before I sit down? Yes, Jody? I'm sure, and we need to talk.
Mm-hmm. Right? Because many people think more is better.
Mm-hmm.
How do you know whether or not someone has already had a lung screening within 12 months?
And you're even bringing up the history-taking importance that you highlighted earlier with PAC years. A lot of patients don't even know the difference between an X-ray and a CAT scan. They're very unfortunately very poor historians about their own health because they haven't been empowered to be in charge of it in a lot of ways. Intense interview taking, both with our administrative team members and our clinical team members. We also, we have the Epic EMR, so we can pull some, of the EMRs through the city. That helps, but it's really about those conversations.
And
yeah.
So then, does Cornell own the patient, or if somebody from
Yeah.
Metropolitan Hospital
Yeah.
sees your van?
Yeah.
And is straight Medicare, so they don't need the pre-op, right?
Yeah.
And whoever's there writes an order,
Mhm.
gives them their scan, but their whole care team is at Metropolitan,
Yeah.
right? How do they get back how do even those results get back to Metropolitan since nobody from there is on the order?
Right. So again, it's all about. Go ahead, Lauren. Yeah. Oh, sure. Yeah, Jody was asking a really great question about if a patient gets scanned, sort of part of this Cornell van, and their care team is at Metropolitan, for example, how do we link them back with Metropolitan, or do we own the patient now? And again, we're not trying to steal patients here. That's not good for anybody. We're trying to ensure equitable care. So if the patient, in many cases, they want to return to Metropolitan, right? We will get their signature to be allowed to send results, but also the images, right? Making sure that you get the discs, making sure that this is a closed loop handoff. Our nurse practitioners are involved so they can have those conversations with the care team. We do have a multidisciplinary review that we do with our clinical team members all through Epic, so it can be done really quickly. So we want to give you at Metropolitan, right, or the providers at Metropolitan, that review as well. So it's all about making sure we get that history. We are working really closely, and I think our primary referral pathway will be through a lot of the federally qualified health centers. So back through that PCP, we can electronically route a lot of that, but we want to get images because they'll need comparisons. All of those things are pointing out, and it's tricky. And I hope that EMRs can continue. Here's my little plug right on policy. And I know everybody agrees, right? We hope that we can continue to collaborate much better than we currently do, for sure. Okay, thank you, everyone.